ACL. And so there's no rush to having your ACL fixed at this point, okay? Because it's not like it's completely torn. But the question is, are you going to still have these episodes of instability? Because ultimately, if the instability was a result of the fact of the ACL, that means we have to probably go and redo the ACL, okay? But that being said, when I went and examined, like I showed you, you had fibers that were intact, and so maybe they just stretched out, and maybe the bigger issue is just the muscle itself is just getting weaker, it's contributing to that instability. And so in any situation, there are times when we have people that have this happen to, and we know it's all acute. We just fix the meniscus, we come back later, and then we take care of the ACL. That's the case. Once kind of range of motion gets better,
right?
Okay, but as you know, you don't need to have an ACL to function. Okay. The question ultimately becomes: are you going to still have stability or not? Because if you still have instability, that could compromise the chance of that other thing healing, right? And so there's really kind of two ways to play this. One way is we let you go through rehab, see if the meniscus heals, and we see if you still feel unstable, okay? If that's the case, we come back and then we redo your ACL, okay? But that's another rehab, right? As you had before, which is quite a while. And so that's one way to go about it. The other way is we get your range of motion back, and then we just go ahead and we fix your ACL, okay? Now, again, that's more rehab, right? And you have a lot going on, in terms of, all the work you have to do and everything, right? And so kind of my thoughts are it's reasonable to see how stable your knee ultimately becomes, and then we kind of go from there. Because if you feel like it's confident, it feels good, go ahead.
I want to get myself going over this now over the last 20 years.
Yep.
I can tell you, especially after talking to you and actually seeing, I can tell you this has been happening.
Yep.
All the time.
Okay.
Not that severe.
Yeah.
I've been playing basketball. I was in college playing basketball, and I felt it made me like, stop. So I just stopped playing.
Yeah.
Limped a little bit back to my dorm room, and it was fine. I can tell you that Achilles tendon, whatever in there, might in the fray and might be the instability.
Yeah.
It's not comfortable at all. This is just it's so bad or got so bad that I was pretty much standing still when it just happened in the airport. You know what I mean? Like it wasn't anything strenuous. Like when I tore my ACL, it was a hard jump stop playing defense, and it just went. This what I'm standing still, okay, and it's the
So I mean, if that's really how you feel, and that's the case, then probably the answer would be to fix it. But the other thing is kind of there are areas in your knee where you have some wear, right? So the thing is, we can't correct necessarily this, right? So it may not get rid of all the pain per se, but it will give you more stable knee at the end of the day. And what I would, if that's the case, I still would like you to do some rehab first, get your range of motion back, get your knee to get fully straight, get you some quad strength up, and then what we do is, once all that kind of gets shored up, your range of motion gets better, then we go back and we fix your ACL, okay? Now, I want to see you, obviously, like I'm not saying we book you for surgery for that part now, but basically the next thing for you would be to kind of get your quad strength up, get your range of motion back first. Once we get all that back, then I'd say it's reasonable, and probably I imagine like the next 3-4 weeks would be reasonable to go back and we take care of your ACL. But what I would say is we talk about it again, probably in about 2 or 3 weeks, okay?
When you left it to me, I had time to think about it, so I gave everybody a warning and said this is because when you said it out on the phone, it made sense. I'm like, you know what?
Yeah.
That's it. I could not figure out why it happened until you said it might have been. I said, that's it. Yeah. That's been happening, the little clicks. And I won't say it's been tearing or whatever, but it's been moving. Like it's been some shifting in there to the point, and it happens at random times, jogging.
Yeah, because typically when you bucket that way, sometimes it does happen, the ACL's okay, but when I got in there, I said, there definitely is some fraying there. And the thing is I don't think that it's necessarily not where it's fixed per se. I think it's maybe stretched out a little bit, or over time what happens maybe repeatedly, it's stretched out enough where now it's not giving you the support you need. In any situation, what we can do is we can take the fluid out today, and then what I would say is I'll talk to Kayla, maybe come back and see me, I would say, in about 3 weeks or so, see how your range of motion is. Once that's good, then I think we go back and we take care of fixing your ACL. And now, they used an Achilles graft on you. They did. So they used a cadaver when you had it done. How old were you when you had that done?
Junior in high school, so 16, 17.
Okay. All right. So What does have to do a little bit of surgical planning, because if you already had an Achilles, did they talk to you at that time about using your own tissue? Or
yeah, I was playing basketball, so they didn't want to take it from here.
Okay.
Because the purpose was to get back to playing, so they figured it would be stronger to go that way, and I was totally freaked out. But a dead body person, pardon me, at that age, so I'm like, I don't know, but that was the best option, because it said it could possibly make my hamstring?
Hamstring, yeah.
Weaker, and they took the graft from there.
Yeah, so there are pros and cons to like all these different grafts, and they're all essentially fairly good options. The bigger thing with the graft is we know that when you take from like a cadaver, in a younger individual, there's a higher chance of it having a re-rupture. Okay.
Really?
Yes, when you're younger, we didn't know that necessarily.
20 years ago.
20 years ago, right? But the advantage in that situation is you're not taking from yourself, right, to make a new bundle of collagen.
I mean, I plan on me being active. I don't plan on trying to win an Olympic medal or anything. So you gotta take it from here.
Yeah, but that's the other option, is we still use your tissue. At this age, it ultimately really kind of depends on you, right? If you feel like you kind of, from a rehab standpoint, sometimes doing it from a cadaver is a little bit quicker, but again, it's not your tissue, right?
Right.
So that's kind of the disadvantage. Now, the other thing is you already had a surgery once, so that's going to change some stuff that I would do like in the operation, but. We can talk more about kind of graft options, I think, kind of once we know we're going to get it on the books and everything, or I can always give you a call about it. We can talk about it a little bit longer, but I think at this juncture what we do is we take the fluid out, get you in the therapy, get your range of motion back, and then maybe in like 3-4 weeks come back and take care of your ACL. The other thing is your diabetes a little bit under control yet, or?
I mean, I haven't gone back and seen yet. Like I said, like when I got my number taken at surgery, they said it was good.
It was good. Have you had your A1C checked yet?
Not since. It was borderline high, so they put me on the stuff 3 months ago.
That's better. Okay. Yeah. So it's because like the other component of that is like obviously ACL surgery is a little bit more involved, and so we have to make sure healing standpoint and everything like that. And so, from that standpoint, if all that it's okay, I think.
From my point, it's under control. I haven't been admitted to the hospital or anything. It's just she ain't even bothered to check and see, hey, how you? It's just all right. Take this metformin. It's kind of a precaution. But I'm trying to get off of it, so that's why I've been becoming active, and I lost a lot of those 30 pounds. I'm trying to just get back into the gym and stuff and do stuff.
Yeah, I think that's totally reasonable. I think that's what we'll do. Let's take some fluid out from you today. Work on getting your knee completely straight, kind of getting your range of motion, then kind of bending in therapy, and then come back and see me in about 2 to 3 weeks. If range of motion, just like you kind of bend the other knee, is kind of getting there where you're like a little bit past 90 degrees and it feels okay, because I do want to see you get good range of motion first. Then we come back and take care of you. And that could take about a month, but that's okay. It's okay to stage, not do everything at the same time, because sometimes the concern is when we fix everything, you lose a little bit of that motion. I don't want that to be an issue. And the next time we talk, we'll talk about kind of like the pros and cons of using like a cadaver again, or using kind of using your own tissue. The tricky part is if you're diabetic and we're using your own tissue, we may end up using some cadaver anyway. That's possible.
I see.
But
I like this diabetes thing. This sucks. I don't like this.
No, but I think if really the issue is instability in your knee, then we take care of your ACL. Make sense?
Yeah, it makes sense.
Okay. So you're okay with us taking fluid off today? Yeah. Okay. You have any questions for
me? No, but do you know Dr. McCluskey from Shore Orthopedics? Did you ever hear of him?
Is he still practicing?
I don't know. That's who did my surgery.
Yeah.
I just know. I figured you said you knew some of the surgeons.
Well, yeah, because Rothman actually, Rothman Institute actually kind of took over a lot of the practices in that area.
I can see.
Yeah. But Dr. McCloskey was his name. I could look him up real quick. So we're gonna take some.
Or it's the Dr. Zabinski's team. It's that office. Yeah, they did my name. My mom, they reminded me who it was. I couldn't remember the name, but I'm like, yeah, that's on this
Shore Orthopedics. Okay. Were they? And so how far?
Dr. Fernando De La Soda did my back.
Oh, really?
Yeah, I know you had to hear him. Yeah.
Oh, really? I know. I did have to.
You had to hear that name. I'm not saying he's world famous, but I mean, like everybody mentioned. Oh yeah, everybody got their back done in Jersey.
Yeah, I actually know his son. Believe it or not.
Oh, do you?
Yep.
See, I'm telling you.
His son's a radiologist. So.
All his teddy bears and stuff.
Yeah, small world. Okay, I'll come back in a second.
Okay. Sorry about that.
All right, Mr. Gilliam, I just need you to sign here saying that you're consenting to the aspiration or draining of fluid from your knee. Okay. Oops. There you go. Just with your finger in that box in the middle. It might be a little uncomfortable. You'll probably feel the poke from the needle, but shouldn't be too bad. He does inject some lidocaine into the knee first to numb it up a little bit, but some people do experience some.
Yeah, I've never had to have this done yet.
Oh yeah?
Yeah, I've heard about it.
Today's your lucky day.
When I had my AC, I just knew that was going to happen. They never did it. he is. He is so cool. Dr. Carter.
Oh, yeah. Yeah, he's awesome. So, yeah, you get to keep all those pictures.
See, that's look at that, y'all. It was like shredded mess.
Yup, you sure did a number. At least to your meniscus.
Now it looks like that. Okay. That's cool. Pause this thing. So everybody, so you were waiting to get my knee drained. You heard the doctor, you heard the prognosis, you heard what the next steps are. So we're going to see what happens, and we're going to get this thing right. I have full confidence in this team, and it was the reason why I was brought here. So I'm gonna let them torture me some more and take some fluid out of my knee. I'm really smiling at the man, so I can't see.
All right, hang out for just a minute.
Sure.
We'll be right in, okay?
All right. So I keep wanting to turn it off, but they come in pretty fast. So there's the, oh Lord. See, I don't, why is there two needles? Why is there a big joint and then there's that one? I don't like that. I don't like it. You know, like, me want to change my mind.